Hello, everybody. So we would actually like to welcome everybody to the day 4 of the Bloodless Medicine and Surgery Week. And so far, it's been a great program, and we'd like to thank everybody for their support. And so today also, it's a very interesting program, and we have a wide range of presentations. So we have our OB-GYN specialists, and we have our pharmacists as well as a pediatric orthopedic surgeon. So it's going to be a very interesting program today. And the first person, actually, I would also like to introduce. I have a co-moderator as well, Yvette Bunch, and she is actually previous former firefighter and EMT, and she had also started a program in the 1990s. So she will help moderate the program together. And so without further ado, we can actually start with the first speaker. And so we would actually introduce my colleague and also a very respected ONG consultant in Malaysia. This is Dr. Sharmini Parampalam. And so she is actually a consultant ONG for 32 years in Pinang Hospital in Malaysia. And she is actually the vice president of our Malaysian Society of Patient Blood Management, of which I'm also a member. And she has definitely been an advocate and also a champion of patient blood management. So she's going to present on the first topic, which is actually optimizing the haematocrit in obstetrics the rational way. So I would invite her to speak to all of us. Thank you.
Thank you, Dr. Ananti, for those kind words. And I would like to thank the organizer, Dr. Osoro, for having invited me to share our Malaysian perspective of patient blood management. Just let me put on my slides. Okay, so the task given to me today is to talk to you on optimizing the haematocrit in obstetrics the rational way, and this is the first pillar. So as defined, the patient blood management is the timely application of evidence-based medical and surgical concept designed to manage anemia, optimize hemostasis, and minimize blood loss in order to improve patients' outcome. And this is patient focused and not product focused. I'm sorry, there's a problem here. I'll try sharing again. All right. So this is patient focus and not product focus. So inpatient blood management, we do not need to transfuse patients who do not need blood urgently. However, those who require transfusion, they should receive the minimum amount of blood that will keep them safe, and it should be given quickly. So the history of patient blood management hails back in 2005 by Professor James, who actually realized the focus of transfusion medicine should be changed from blood products to patient. And this was further endorsed by the World Health Assembly. And in 2017, it was recommended as a standard of care by the European Commission. And the WHO Action Framework has actually listed patient blood management as one of its 6 goals. So in optimizing hematocrit, what we would do is peri-operatively or pre-delivery, antenatally, we would screen the mother for anemia. We would identify and manage the underlying disorders causing anemia, and we should treat the iron deficiency anemia of chronic disease. And intrapartum or prior to delivery, we should actually ensure that the patient is hematologically optimized. And in the post-op period, if she has suffered a postpartum hemorrhage, then we should correct that anemia by giving iron, which could be oral or it could be IV iron. So the measures during pregnancy is first to identify anemia and its cause, then to treat it, then early treatment of iron deficiency, optimizing red blood cell before delivery, and identify women who are very high risk of postpartum hemorrhage and plan their delivery in a tertiary hospital. And if possible, we will arrange for a cell salvage so that they can receive their own blood as a replacement. Antenatal anemia is a modifiable risk factor, and it is a predictor and is definitely associated with higher incidence of perioperative blood transfusion, alloimmune sensitization, and surgical site skin infection. And because of these problems, there may be prolonged hospitalization and even increase in hospital costs. And this is an independent risk factor for venous thromboembolism. And anemic mothers can actually also die from this condition. So what is the burden of iron deficiency globally? WHO has defined anemia of a hemoglobin of less than 11 grams per deciliter in a menstruating female. And in pregnancy, at term, we expect the hemoglobin to be more than 10.5 grams. Sadly, more than 30% of the world population is still anemic. And anemia in pregnancy and patients going for elective surgery is definitely an independent risk factor for morbidity and mortality. In the past, we actually saw topping up of hemoglobin using blood, but I think today we have changed our management using the patient blood management, in which we resort to iron if there is iron deficiency anemia and correction of anemia. Blood transfusion itself is an independent risk factor for poor clinical outcomes. And the reason these drivers, there has been a paradigm shift from product focus to patient focus in transfusion medicine. In this article in the British Medical Journal, Improving Patient Blood Management in Obstetrics, An audit was done in a tertiary hospital, and it was found that 12% of maternity patients who had postpartum hemorrhage, primary postpartum hemorrhage, were really anemic on admission, and there is enough evidence to show anemia increases your risk of postpartum hemorrhage. And of this group, 58.3% required transfusion, and when it was compared to women who were not anemic, only 17.88% actually required transfusion. So correction of anemia in the antenatal period is definitely crucial. In Malaysia, among pregnant women in Malaysia, 80 to 90% of them have low iron status, and 38 to 40% of them actually go on to develop anemia. The American College of ONG has put up this to say that active identification and correction of anemia for all preoperative cases is essential, and that is what is actually practiced in our hospital as well. So women who have heavy menses are one of those who are prone for iron deficiency anemia. And if they have a ferritin of less than 20 nanogram, definitely they're prone for iron deficiency anemia. So poor outcomes of anemia prior to surgery. In the study, they compared anemic patients and controls, and they have seen that anemic patients, among anemic patients, those who required transfusion was 71% compared to non-anemic patients, which is 10.5%. And among those who are anemic, they were also prone for higher risk of urinary tract infection as well as respiratory tract infection compared to the control group. So when do we diagnose iron deficiency anemia? We will send the iron studies, which comprises ferritin, total iron binding capacity, and transferrin saturation. And if the ferritin is less than 30 nanograms and the transferrin saturation is less than 20%, then we would make a diagnosis of iron deficiency anemia. So what are the benefits of patient blood management? It definitely has better patient outcome, and it is cost effective. And in this study, we have seen that there's a reduction of transfusion with the practice of patient blood management for up to 95%, and mortality has reduced up to 68%, and the length of stay in the hospital has reduced up to 33%. Readmission and re-surgery has also reduced by 43%. Reduction of morbidity up to 41%, and the length of stay in the hospital has also reduced. So is it time to change our transfusion practice? Yes, because we know that blood transfusion has got safety issues. One is infections that can be transmissible, namely the HIV, hepatitis, and even the COVID-19 infection. And of course, transfusion doesn't go without any risk of reaction. And studies have shown that there's increased morbidity and mortality and adverse outcome in patients who receive blood transfusion. And there's an increase in the cost of blood. Blood is not free. And of course, with the aging population, many parts of the world, in fact, in Malaysia and in Pinang too, sometimes there's a shortage of blood supply. So, with blood transfusion, these are the possible things that can happen, from infection to embolism to pulmonary complication to increased admissions to ICU and length of stay, and of course, increased risk of hospital mortality. So is the stored blood actually as good as giving a fresh blood? Definitely not, because the stored red blood cell loses its nitric oxide and is not able to deliver oxygen in the same way as fresh blood is. So the blood storage lesions, what happen is that storage lesions results in depletion of ATP to 3-DPG, decrease in nitric oxide, decrease in tissue perfusion, and increase in inflammatory products, which then results in decreased oxygen delivery and increased inflammation and bacterial infection. Now, when do we decide to transfuse? For preoperative transfusion, in 1942, Adam and Lundy proposed the 10-30 rule, where the hemoglobin should at least be 10 grams and the hematocrit should be 30%. But In 1999, this was reverted by Herbert, who studied the effect of restrictive strategy versus the liberal strategy, and a hemoglobin of at least more than 7 grams would definitely be effective for the patient to undergo a surgery. We know that 40 to 60% of transfusions were inappropriate, and the modifiable risk factors that contributed to transfusion is the presence of correctable anemia, excessive surgical blood loss, excessive blood loss due to unnecessary testing, uninformed and poor transfusion practices. So it's time for us to focus on our patients and not on transfusion, and transfusion should actually be our last resort. We should plan early, have adequate time to improve the hemoglobin of our mothers who are pregnant prior to delivery, or for our patients who are going for surgery as well. And if we resort to transfusion, then we should try to practice a single unit transfusion. Restrictive blood transfusion threshold and reassessment after single unit transfusion should be incorporated into clinical practice in all areas. Looking at the health economic perspective, patient blood management falls under the prime quadrant. It has good outcomes. There are numerous papers to show this, and it is cost effective as well. In our hospital in Pinang, relating to this topic, we have done a couple of audits from the year 2007. The first audit was done when we realized that many women admitted with heavy menstrual bleeding were actually given blood transfusion. And what happened was the junior doctors were just looking at the number on the blood form and transfusing patients. So we prepared a new guideline where we had to assess the patient as a whole, looking at the hemoglobin, the vital signs, and the symptoms if the bleeding was controlled with other medication or measures. And with that, we were able to reduce our transfusion from 55% to 7%. A second audit was done looking at the cross-match transfusion ratio in our department as well. And usually the obstetric and the ONG team, we have a gynaecologist in our services in our hospital. Hence the request for blood prior to surgery is a lot, but however the transfusion is reduced because they take measures to reduce blood loss during surgery. So what happened was rather than just requesting for 4 pints of blood, we came up with a maximum surgical ordering schedule based on the usage of blood for different types of surgery. And with this practice, we were able to reduce the cross-match transfusion ratio from 6.7 to 2.4, which is what is a norm in Malaysia. A third audit was done recently, and this looked at the improvement of hemoglobin with antenatal iron infusion. And we have mothers of different age groups and different parity at different gestational age who came in with a HB of 7.8 up to a HB of 10. And these mothers were actually given IV iron, and their increment of hemoglobin was from 8 to about 42%. Another audit was done for postnatal mothers who actually suffered from postpartum hemorrhage. And in these mothers, we didn't use blood to correct their hemoglobin, but we also resorted to IV iron, which is given immediately after delivery prior to discharge. And in these women, we were able to increase their hemoglobin by about 42%. So iron replacement in Malaysia are available in 2 forms, oral iron as well as intravenous iron. And the oral iron that's available is ferrous sulfate, ferrous formulate, and ferrous gluconate. And as we know, oral iron, bioavailability of iron is only 10 to 15%. And there's always an issue with compliance. Mothers actually don't like taking iron because of the odor and the aftertaste. So the IV iron that's available is Venofer, Cosmofer, and Monofer. And in our hospital, we use Venofer for our pregnant mothers. So correction of antenatal iron can be done by using oral or intravenous iron or even recombinant erythropoietin. In cases where we anticipate heavy bleeding during surgery, like an adherent placenta or a placenta previa, we should actually plan to self-salvage and transfuse or to transfuse the mother's own blood. The NATA consensus statement is something that we also follow in Malaysia. All mothers who are pregnant actually have their hemoglobin checked at booking at 28 weeks. And in Malaysia, we do it again at 32 weeks. And if they are found to be low, then we will send off we will send off a serum ferritin, as well as we will look out for hemoglobinopathies. And in this statement, it actually says all mothers should be offered iron. If their serum ferritin is less than 30 nanogram, as a preventive measure, they can be given 30 to 60 milligram, and in a therapeutic form as 80 to 100 milligram. We know the problem with oral iron absorption, and because of hepcidin, it prevents the enteral iron absorption and transport of iron from the liver, and therefore less iron is delivered to the bone marrow to give effective erythropoiesis. In this paper, they have actually looked at administering iron every other day, and what they have found in this Swedish paper was the alternative dosing of iron may maximize the fractional iron absorption, increase the dosage and efficacy, and reduce the GI exposure to unabsorbed iron. And once oral iron is used to correct hemoglobin, the hemoglobin can be checked after 4 weeks. So when should we resort to intravenous iron? When the patient is not responding to oral iron, when there's an urgency to top up hemoglobin, and when there's a massive bleeding is anticipated antenatally, postnatally, or intraoperatively or intrapartum. At the moment, we have not given any intrapartum or intraoperative IV iron, but we are quite comfortable giving it antenatally and postnatally. And the iron required dose is calculated using the Gansoni's formula. Is IV iron safe? Now, these newly approved and safe iron formulations are quite safe, and ferric carboxymaltose iron sucrose is quite safe, and the reaction with IV iron, which was previously seen, was with the high molecular weight iron dextran that was available, which is now improved and safer to be used. So when we look at the toxic effect and the immunogenicity of iron, the one that gives us the best result is probably the ferric carboxymaltose, because it has low toxic effect and low anaphylactic risk. Previously, high molecular weight iron dextran was actually taken off from our formulary, but now with the new dextran available in Cosmofer, it is in, and we are already using it. So IV iron may be indicated when there is a need of rapid increase of hemoglobin and iron stores are required. And when in Malaysia, when we compare the price of 1 Paxel, which is about 500 ringgit, with 2 ampules of Venofer, which contains of 200 milligram of iron, we are actually paying 14 times higher for blood than IV iron. So who needs patient blood management? I think the WHO has called out an urgent need to implement patient blood management. And PBM is definitely essential in pregnancy and childbirth, looking at this literature review and expert opinion. Definitely, patient blood management demonstrates a reduction in morbidity and mortality, cost for patients undergoing surgery and medical intervention with high bleeding potentials, and all pregnant women have a significant risk of postpartum hemorrhage. So risk factors may not exist in some women who actually experience postpartum hemorrhage, and therefore every obstetric unit should practice patient blood management and focus on women who will be identified as high risk for postpartum hemorrhage. So what are the barriers to patient blood management? There are multiple barriers. The first is a lack of knowledge and interdisciplinary commitment for a PBM guideline in clinical practice. The next is, I think, patient blood management should be hospital-centered so that it's practical, feasible, and acceptable with all the departments in that institution. And what we need is, what we lack is clinical champions and strong leadership in order to establish PBM. And lack of education and training is one of those that deter people from practicing PBM because of lack of awareness. So lack of knowledge of patient blood management among clinicians can be a challenge or a barrier, and they don't think that patient blood management is high in their priority. And some of them actually think that IV iron is very expensive, and they think that blood comes for free, which is a false perception, as I have shown earlier. And there is a lack of knowledge among patients that blood transfusion is not without risk. I think in order for PBM to move forward, we need patients to come up and ask for it. And I think at every country to bring up PBM, we must have a national authority on this, and it should be endorsed and practiced by all hospitals. So who owns patient blood management? For me, I think it's everyone's responsibility. And I think if the patient is going for a surgery, then preoperatively, it would be the anesthetist, the surgeon, and the primary care physician. Intraoperatively, again, the anesthetist, the surgeon, the perfusionist, and the specialist, as well as the nursing staff. And postoperatively, again, the whole team has to manage the patient and manage patient blood management. So some bring home messages: don't neglect anemia. If we treat it soon and treat it effectively, and we may need to consider using IV iron to get a quick improvement in their anemia status. We have to know the first pillar well. It may be unique for each discipline, but definitely the first pillar is where it begins. And we need to think twice before transfusing, as if I say that you need to have a kidney transplant or a liver transplant, people will take it very seriously. But we don't realize that blood is actually a liquid organ transplant. And I feel that in every unit, the transfusion should be the decision by the senior most person, should be the consultant or the specialist. And blood bank and transfusion units should actually start questioning the reason for request for blood. And if we need to give blood, then try to practice a single unit policy, unless it's a massive transfusion protocol has been activated. Iron deficiency is an important modifiable factor, and early investigation and treatment should be given before it progresses to iron deficiency anemia. So we can always resort to IV iron. And in my hospital, we are quite comfortable giving IV iron. I think in a day, we have 2 or 3 patients who come in on a daycare basis and have it administered, and they are discharged. And in post-operative anemia, we should also use IV iron. So transfuse only if it's absolutely necessary, and it's the single unit policy. Assess the patient as a whole, or not just a number on the lab form. The Society of Advancement of Blood Management has said that I think if we should postpone surgery because we need to optimize the hematocrit, and we have to stop unnecessary blood testing. And we should go clinical, not just looking at numbers on investigation. And we should transfuse if transfusion is not a default decision, and we should only do it if it's absolutely necessary. So what are the challenges to clinical leadership? The greatest difficulty in the world is not for people to accept new ideas, but to make them forget their old ideas. In our journey for patient blood management, actually, we were able to actually convince the people with old ideas, but to incept this patient blood management among the younger generation of doctors is a challenge. So when it comes to obstetrics, I think every mother is special. So stop, think, identify the cause of anemia, plan what is best for the mother, correct it antenatally, and then give her what is required, and proceed on to bring in a live baby and a happy mom. So to win patient blood management at your hospital, I would like to share some of the things that I think in my thoughts are useful. First is you need a champion, and you need to lead by example, and it must be a team effort. There must be advocacy going on, and reminders and rewards for those people who actually practice patient blood management. And there must be a change culture. Frequent audits is necessary to show evidence that it is working, and it is useful, and it is beneficial, and it is not a very difficult process. Giving IV iron is definitely simple compared to blood transfusion, the amount of paperwork that is required. There should be benchmarking, and this must be a new norm. So the PBM journey starts with convincing everyone, obtaining their commitment, making them change, and finally it will be a win when everyone is comfortable with patient blood management. So establishment of patient blood management offers a reduced risk and improved patient outcome in perioperative pathway and in obstetrics as well. There are three pillars of PBM, and all three are equally important. Collaboration and continuous effort to translate PBM guideline into clinical practice should be multidisciplinary, organized in a structured way, will make PBM the norm. So patient blood management, I hope in the near future, will be patient driven, and patients who come in will tell us they would not want blood, but they would want iron instead of blood. So please adopt and adapt patient blood management. Okay, with this, I thank you, and I will be ready to take some questions.
Thank you very much, Dr. Sharmini. You definitely did an exceptional presentation. And I think you yourself are already a champion in patient blood management.
Thank you,
Yeah, yeah. So it is actually a very nice part that you mentioned that, transfusion rates like drop from 55% to 7%. And so you actually save so many people from the bad effects of transfusion. And you actually gave good outcome. So we have the questions and quite a bit later. So we will go through the presentations first, and hope you can stay on, and together with the panelists, we can answer the questions.
Right? Sure, I'll do that. Thank you, Ananthi. Thank you everyone for listening.
Yeah. All right. So just now we learned about the use of IV iron and how we can actually optimize, but also what about the other therapy, right? So we're going to learn also about oral iron therapy with ups and downs, but still effective. So I'm going to introduce to everyone our next speaker. She is Onyinye Isiguzo. She has a bachelor in pharmacy. She's an assistant director of pharmaceutical services in the Department of Pharmacy in the Federal Medical Center, Nigeria. And she's an active member of the local Bloodless Medicine and Surgery group in her institution, as well as a member of the Bloodless Medicine and Surgery Society. And Isiguzo is definitely a strong advocate of transfusion-free medical care and a patient right advocate. So without further ado, I would like to introduce and invite Onyinye Isiguzo to give her part. Thank you.
Thank you, Dr. Ananthi, for the warm introduction. And thank you, the organizers of this, for the privilege to speak on this very important program. So as we've heard, we'll be discussing oral iron therapy. Okay, let me share my slides. So we'll be discussing oral iron therapy, its ups and downs, but still effective. We'll be using the following outline for our discussion. During the week, a lot of people had said one thing or the other concerning oral iron therapy. And I want to give a brief summary of why we are interested in iron as a way to introduce this. So let me hide this flow thing. Okay. So iron is a micronutrient that is essential for life, as it's a component of the oxygen transport protein, the hemoglobin. The interaction between iron and oxygen is important in the transport of oxygen by the hemoglobin. In humans, iron exists as a component of the heme, and in the heme ring of a deoxygenated hemoglobin, the iron has one of its coordination sites free to which molecular oxygen reversibly binds, and this interaction is what helps in iron transport. Iron is also important for the adequate production of the red blood cells. And the red blood cells, they are the most numerous cells of the body, accounting for about 84% of the total body cells, with the rate of production at 200 billions per day or 2.5 millions per second. So daily, we require iron to reach the erythrocyte precursors of the bone marrow, and the amount of iron required for erythropoiesis is between 20 to 25 milligrams. The body also needs to store iron. For males, the total body iron content is about 4 grams, and for females, we have about 3 grams. This body iron content should be kept at a constant, as an overload would be detrimental, as it will facilitate the production of toxic reactive oxygen species, which would also be detrimental to the system, and a deficit of iron would cause anemia. In bloodless medicine and surgery, we are interested in iron replacement therapy because it's geared towards optimizing the hematocrit. And currently, the efforts are in increasing tolerable blood loss and the margin of safety in event of blood loss in surgery, and in reducing morbidity and mortality in non-surgical patients. Iron therapy is there with or without the erythropoiesis stimulating agents. So you could see we are dealing with the first pillar of bloodless surgery, optimizing the hematocrit. Let's take a brief history of iron replacement therapy. It entered into the world scene by the 17th century when a man, Thomas Sydenham, proposed the use of oral iron salts for the treatment of chlorosis. This is a disease of adolescent girls and young women, which initially was thought to be a hysterical disease, but later found out to actually be due to iron deficiency. And by the second half of the 19th century, the first iron prepared to be used through the intravenous route came into the world scene. That is the iron saccharide. One would think that there was progress since the 17th century in the use of iron replacement therapy. But this didn't happen because of the problems that were inherent with the traditional compounds. It wasn't until the 19th century whereby improvement in pharmaceutical technologies allow for production of new iron formulations that minimize these problems that we saw increase in the use of iron replacement therapy. So, who needs iron replacement therapy? One, we have patients who are undergoing renal dialysis. Blood loss in this patient is such that for us to maintain their target hematocrit level, they need iron replacement therapy. Iron replacement therapy is also essential in addressing iron deficiency with or without anemia, in bloodless medicine and surgery, in pregnancy, and in patients with dysfunctional uterine bleeding who are scheduled for hysterectomy. There are 2 types of iron preparations available, the oral and the parenteral. The former speaker talked much on the parenteral, and now we are focusing on the oral. There are 2 sources of that. We have the dietary iron and the oral iron salts. The dietary iron is the iron we get from our diet. It consists only a small fraction of the iron we really require, but it's very important in replacing the daily iron we lose during the traffic in the cells. Daily we would lose about 1 to 2 milligrams of iron, and it's estimated that for a standard European diet, one could get about 10 to 15 milligrams of iron, of which only 10% of that is absorbed. So if 10% is absorbed, we are looking at 1 to 1.5 milligrams. As such, you could see that it could offset these daily iron losses. That is why in secondary prevention of iron deficiency, dietary iron is of great value. And in maternal and child health, its value cannot be overemphasized. However, dietary iron cannot be relied upon as treatment when there is iron deficiency. There are 2 primary forms that dietary iron comes in. We have the heme and the non-heme iron. This non-heme iron is mainly gotten from plant-based foods. The iron in this non-heme is in ferric form. It needs to be reduced at the duodenum by the brush border ferric reductase with the aid of the duodenal cytochrome B to the divalent ion before it can now be carried by the divalent metal transporter into the enterocyte. As a result of this requirement, it has poor bioavailability, and only about 17% of that is absorbed. And then we have the heme iron. It's mainly gotten from animal-based foods, and the iron is in ferrous form, so it has high bioavailability. About 25% of that is absorbed. We'll say that high protein diets generally improves iron supplementation. I've tried to put up a table that has some local foods and their iron content. This information is quite helpful for mothers, and also when we have fast-growing children who will require a lot of iron in their diet, we're able to plan the diet properly so that our children can get what they require. Then we move over to the oral iron salts. The oral iron salts are effective means of increasing the hemoglobin levels. They are cheap and they are very safe. They are also important in restoring iron stores. They vary widely in their dosage and the type of formulation they come. Some have iron which is quickly released, others come as a prolonged release. And then they also vary depending on the chemical state the iron they contain is in, whether it's in the ferrous form or in the ferric form. As we've seen, the ferrous form is better absorbed. These are some examples of some oral iron salts we have available. The iron polymaltose complex and the scrosomia iron are the more newer types of oral preparations we have. Iron preparations can come in form of tablets or capsules or syrups, elixirs or drops, all aimed at enhancing its appearance and taste, thereby encouraging the compliance by patients. Oral iron salts are suitable and effective for first-line therapy for iron deficiency, and even when there is iron deficiency anemia, and also in obstetric patients. Different oral iron salts, they have similar efficacy and tolerability when you give them at equivalent elemental iron doses. As we progress, we would understand this better. Usually, for an adult, it's recommended that you get up to between 100 to 200 milligrams of elemental iron, and this is better done in 2 to 3 divided doses. Reticulosis is expected to occur after 72 hours you've administered therapeutic doses of oral iron, and the HB levels should rise to about 2 grams per DL after 3 weeks of oral iron therapy. But if after 3 weeks of oral iron therapy and the HB rise is less than 1 gram per DL, this would define iron refractoriness. But for us to conclude that the patient is refractory to oral iron, we'll have to rule out conditions that would cause malabsorption of iron, like the presence of H. pylori infection, celiac disease, or when there is autoimmune gastritis. The divalent form is the most appropriate form of oral iron used in oral iron replacement therapy. We've seen why. The most being used is the ferrous gluconate, the fumarate, and the sulfate. The sulfate is more popular. So, when this iron gets into the system, because of the acidic concentration in the GIT, it enables the ferrous salts to release the iron they contain. This ferrous iron enters into the enterocyte through the help of the divalent metal transporter. The divalent, once it's in the enterocytes, it now needs to move out through the intestinal ferroportin. That's the channel through which iron is exported out of the cells. And it needs to be carried by the transferrin in the plasma. But for this to happen, this ferrous iron need to be oxidized back to the ferric form, and that will be done by the ferric oxidase, which oxidizes it back to the ferric form, and it is now ready to get attached to the transferrin in the plasma. From there, it is now distributed to the target organs, to the liver for storage, and spleen also for storage, and then to the bone marrow where erythropoiesis should occur. So we've seen that ferrous salts, they are favored by absorption, is favored largely by a mildly acidic medium. And that is why co-administration of iron with ascorbic acid, as our vitamin C, improves its absorption. And the goal of treatment when we are giving oral iron therapy should be to normalize the hemoglobin and also to replete the iron stores. You don't want to do one and leave the other. This is a table that shows the elemental iron content of some oral iron salts. Like we said earlier, depending on the iron salt you want to use, First, we could see that ferrous sulfate will give us a tablet of 325 milligram, will give us about 20% elemental iron. That is bringing us to like 65 milligram of elemental iron. If you want to use ferrous sulfate, that means if I give my patients this tablet 3 times a day, I would get the recommended 100 to 200 milligram. But if I want to choose ferrous gluconate, I wouldn't want to give it 3 times a day. You need to double the dose, realizing that ferrous gluconate will give you only 10%, which is half of what you get from ferrous sulfate. Provided you take this into consideration and dose your oral iron properly, you will get similar efficacy from the irrespective of the oral iron salt you use. Oral iron, however, has its limitation. One, we have compliance issues. The 2 to 3 times dosing, most patients don't comply. A lot of us forget the next dose. I do too. Then we have tolerance issues with iron. The ferrous always cause GIT irritation, and some patients don't tolerate this. Then there are comorbidities that may impact on the absorption of iron. And when this happens, oral iron will lose its efficacy. Then in patients that have chronic renal impairment who are receiving erythropoiesis stimulating agent therapy, oral iron will not give us the desired result. And when there is ongoing iron losses that exceed absorptive capacity, and when you require rapid iron repletion, oral iron would not be the therapy of choice. Now, to improve on some of the problems inherent with the traditional oral iron salt, another new formulation of iron came into the world scene. It was launched in the 1990s. That is the iron polymaltose complex. It took away the problem of ferrous, which is GIT irritation, and then interluminal chelation and poor bioavailability seen a lot with the ferric salt. The iron in this polymaltose complex is already in the ferric form, but is now chelated, avoiding GIT irritation. It consists mainly of a ferric hydroxide core that is surrounded by polymaltose molecules. This structure is also similar to the physiologically occurring ferritin that we find in the enterocyte. So it's easy for it to enter there. And once it gets in contact with the iron binding site at the surface of the mucosal cells and releases just the required amount of ferric iron. Iron polymaltose complex releases its ion based on a particular feedback mechanism. Its rate of ion release is determined by the availability of the ion binding carrier proteins, that's the transferrin. So you see, with iron polymaltose complex, there will be no free ion, unbound ion available in the system that will cause system overload and as such stimulate hepcidin, or that will lead to blockade of the absorption of iron by blocking of the ferroportin channels. So these are some studies that show the evidence of the iron polymaltose complex superiority over other oral iron salts. And it was seen that for long-term supplementation programs, IPC should be considered and not the traditional oral iron salt. And even in pregnancy, because of the way patients comply to it can be taken with food. A lot of pregnant women prefer IPC, and it is good for treatment of iron deficiency anemia during pregnancy. This is a further table comparing IPC with other oral iron salts. We've seen the absorption is active, its efficacy is high. When it comes to system overload, there is none, and it can be taken during or after food. And because the iron in it is in a non-ionic form, it has a delicious taste, unlike the traditional ones that have metallic taste. Then, to further improve on the bioavailability of iron, a newer oral iron has come into the scene, and that is the sucrosomia iron. This is still under study. It's an innovative oral formulation in which the ferric pyrophosphate is protected by a phospholipid bilayer membrane composed mainly of sunflower lecithin plus a sucroester matrix, and that is what is called the sucrosome. So the iron is enclosed by this sucrosome. Because of the presence of this sucroester matrix, it gets into the intestine intact in that vesicle-like structure, and it can cut across through the M cells, the paracellular and the transcellular routes without the need of a specific transporter, from where it enters the lymphatic system, and from there it gets to the liver and other target organs. So because of the way this sucrosomal ion moves, you see that all the iron it contains, it's made bioavailable to the system. So it has been shown to be more efficacious and more tolerable than other oral iron salts. And even in some clinical conditions where absorption of iron was drastically reduced, like the celiac disease, the post-paediatric surgery, anemia in chronic inflammation, then even in iron refractory iron deficiency anemia, studies have shown that sucrosomal iron was found to be effective in these conditions. Further studies has gone ahead to compare the bioavailability of the sucrosomal iron with parenteral iron, and it has been seen that it can be considered as an alternative to IV iron, both for initial and for maintenance treatment in different patient populations, such as the oncohematological patients, in chronic kidney disease patients who are not on dialysis, in post-bariatric surgery patients, even in bleeding patients in internal medicine ward. One thing that's about this group of patients is that usually it was the parenteral iron that was preferred as the treatment of choice for this patient. But studies comparing the bioavailability of parenteral iron with the SI has shown that their HB response is comparable. In oncology, for example, patients who presented with moderate chemotherapy-induced anemia, their performance with oral SI was compared, and it was found out that after receiving oral SI at a dose of 30 mg per day, and another group received the parenteral ferrous gluconate at a dose of 125 mg per week. After 8 weeks of treatment, their HB response was 70% to 71% respectively. You could see the bioavailability was comparable. And then the final HB was greater than 12 gram per dl. And one benefit SI has over the IV iron is that it's better tolerated. Only one person showed GIT toxicity, whereas there were 2 infusion reactions that were witnessed with the ferrous gluconate. Similar studies were repeated in nephrology and in gastroenterology with patients of post-bariatric surgery. It was compared with the IV iron sucrose, and it was also similar results were repeated, showing that SI is comparable to the iron gotten from the intravenous route. Then another benefit oral SI has over parenteral iron is that it's cost effective, as it's cheaper than iron from parenteral routes. It was also observed that pre-operative iron supplementation with sucrosomal iron given 30 mg per day for 3 to 4 weeks helped to reduce the length of hospital stay for patients from 6.5 days to 4 days, and the number of transfused units was also reduced from 7 to as low as 0. Another important benefit of SI is that when it was tested in mice, it showed minor or no significant increase in the liver hepcidin, and we've seen that hepcidin affects iron, greatly regulates iron homeostasis. Anything that will increase the liver hepcidin mRNA or the serum hepcidin levels would affect the absorption of iron. There are also promising results in the use of SI in relation to preventing anemia in pregnancy. Despite all the good results that have been gotten from the use of sucrosomal iron, in order to confirm these promising results, we'll still need to carry out appropriately sized randomized control trials. Some of the trials were done with few number of patients, and these trials also need to be done in different clinical settings to see if these results can be reproduced. Then we can't talk about oral iron therapy without mentioning some of the adjuncts of oral iron. We have the vitamin B12, the folate. They are all very important, as the vitamin B12 is needed in the production of the red blood cells, and folate plays an essential part in hemoglobin production. So when we are giving oral therapy and we add these adjuncts to them, they bring about a synergistic response in the hemoglobin maximization regimen. Vitamin A also is quite important, as it helps the body to absorb and use iron. Foods rich in vitamin A and beta-carotene, such as the carrots, cantaloupes, mangoes, are quite helpful. Zinc is also another micronutrient that is beneficial in the daily absorption of iron, although it may not be so useful in weeks. But it has been found that deficiency of zinc can aggravate iron deficiency anemia, since it's a cofactor of several enzymes that are involved in iron metabolism. Now, how do we dose iron? To be able to dose iron properly, you need to calculate the patient's total body iron deficit. You now determine which type of preparation you want to use, and now decide how many doses of this desired preparation would be enough to offset the deficit. The cumulative dose for iron repletion is usually based on the patient's HB and body weight and should not be exceeded. We have two methods of determining the cumulative dose, the Ganzoni formula and the simplified method. That is the Ganzoni formula. The total body iron deficit is calculated as a product of the body weight and the difference between the target HB and the actual HB in gram per liters of the patient, and also multiplied by the factor 0.24 plus the iron depot. Usually for patients who weigh above 35 kg, the iron depot is about 500 milligram, and patient weighing less than 35 kg, that will be calculated by 15 milligram per body weight. Then this is an example of how the Ganzoni formula can be used to calculate iron deficit in a 70 kg female. The simplified method involves estimating the cumulative amount of iron required to replete iron body stores using the table below. However, caution should be applied when you want to use the simplified method, as it was tried only just on a single study, and the patients that were used had inflammatory bowel disease. Then, how do we administer iron? Oral iron, the traditional oral iron salt, are better given in 2 to 3 divided doses on empty stomach. You can take them with a full glass of water or juice. For children, they can take half glass of water. But this does not apply to the iron polymaltose complex, as we've seen, and also the sucrosomal iron. You may want to eat to lessen the possibility of stomach upset. If you're giving liquid formulations, they have to be diluted with water or juice so that they will not cause tooth staining, or you use droppers to ingest them. The dosing and administration of iron is largely guided by our understanding the hepcidin physiology. We've seen that hepcidin critically reduces systemic iron homeostasis by blocking the ferroportin, that is the channel for exporting iron out of the cells. What happens with the traditional oral iron salt is that they release the whole iron into the enterocytes, which is carried in by the divalent metal transporter. And then this ferroportin opens up for the ferrous ion to come out. When they come out, they are oxidized by the ferric oxidase. But if the transferrin, that is the carrier proteins, are not available, and if enough is not there to mop up the whole ferrous ion that is released, the ion stays in the system and causes a high concentration of serum iron. And this upregulates hepcidin, which now blocks the ferroportin channels without considering whether iron stores have been repleted, and even there could still be anemia when hepcidin does this. So that is why when you're giving traditional oral iron salt, you have to space it enough to allow hepcidin levels to return to normal levels that will allow for further absorption. But we'll see that these problems will not occur when you're using the iron polymaltose complex or the sucrosomal iron. Then, as pharmacists, we're interested in what iron we interact with so that we can better advise our patients properly. We have two of this kind of interactions. We have food and drugs. The food that interact with, that interfere with iron absorption are tea and coffee. In tea, we have the tannins, the oxalates that chelate iron. And in coffee too, we have caffeine. This caffeine inhibits the absorption of iron. Milk has calcium, grapes contain tannins, the pasta products, they contain gluten, the brown rice, our wheat products, they contain phytates or phytic acid, and our peanuts, they contain oxalic acid. And these things will chelate iron and affect its absorption. Whereas fruits such as citrus fruits, the dark green leafy vegetables, bell peppers, melons, strawberries, all these have high content of vitamin C and they improve the absorption of iron. There are drugs that also interact with iron absorption. We have our antacid, they chelate iron and affect its absorption. Then the H2 antagonists, These antagonists, they suppress gastric acid secretion, and this would have an impact on the absorption of iron, which is encouraged by an acidic medium. Then we have the proton pump inhibitors like the omeprazoles. They cause upward regulation of hepcidin, and this now affects the absorption of oral iron. Then ascorbic acid increases the absorption of that. We've seen why. And then when our patients are on these drugs mentioned below, like the Sevdina, the dolutegravir, we want to be concerned because iron decreases their blood concentration. So we want to check to know when we would need to titrate the value of such products. Are there complications with oral iron? Yes, we have the mild to moderate side effects, and the serious to severe side effects are mainly seen with intravenous preparations. The mild to moderate side effects are these: constipation, stomach pain, nausea, vomiting, headaches, and sometimes cough. And then the serious to severe side effects mainly seen with the intravenous preparation. The only one that concerns us with oral iron preparation is that of the change in the gut microbiome, where it decreases the biofidal bacteria and the lactobacilli and increases the enterobacteria, including the enteropathogenic E. coli strains, which is quite discomforting. So what are we saying in summary? We've seen that iron is indispensable to life, and from our diet we can absorb enough iron that could obligate the daily losses of iron in the trafficking that we find in the cells, but it cannot be used for treatment. And when we are giving oral iron therapy, our aim should be to target the haematocrit level and also to replete the iron stores. We don't want to do one and leave the other. Oral iron, despite its ups and downs, is still very effective when there is no urgency and when patients can tolerate it. And newer oral iron preparations like the iron polymaltose complex offers a lot of benefits ahead of other traditional iron salts. In fact, in our hospital, we've used this a lot. And in circumstances when there is significant ongoing iron losses, we don't want to rely on oral iron. We would need to move over to the intravenous iron therapy so as to offset the iron deficit that is needed for erythropoiesis. But although intravenous iron therapy plays a big role in bloodless medicine and surgery program, there are now newer oral iron preparations like the sucrosomal iron, which can now compete effectively with it, give equal results with less adverse effects and more cost effective. So, thank you for listening.
Thank you very much, Onyinye. And that was a very great presentation. And because of what you have presented now, we have a great insight on, more insight actually, into oral iron. And so we will address more questions later, and we can actually proceed to the next speaker, Dr. Craig Eberson. And I would like to introduce my fellow colleague to actually give an introduction to him. I'm going to call upon Kevin Wright, and he actually has been having about 20 years of experience in transfusion-free medicine program. And so he's going to introduce Dr. Craig Eberson. Thank you.
Thank you, Nathi. Nice to be with everyone and to welcome everyone. We've got over 300 participants or attendees this morning, which is good. I wanted to introduce Dr. Eberson because we've worked together. My goodness, I was trying to think back to our first patient, Craig, over 15 years ago, a young girl that had scoliosis, a scoliosis issue that he addressed, and we've been associated ever since. And so it's a pleasure to introduce him. He's Dr. Eberson is professor of orthopedic surgery at the Brown Medical School and attending physician at Hasbro Children's Hospital in Rhode Island Hospital. For those of you that may not be aware, of course, Hasbro Children's Hospital is the premier pediatric facility in this New England area. Dr. Eberson is chief of pediatric orthopedics. He's the author of numerous book chapters, scientific articles, and national presentations related to the orthopedic care of children. His current research interests include the treatment of spinal disorders via minimally invasive approach, improving the success of limb lengthening procedures, and the treatment of pediatric musculoskeletal injuries. I'll add that this is important because, of course, when children need procedures that may involve high blood loss, of course, the threat is always a blood transfusion. And I've appreciated Dr. Eberson's approach, which is so helpful in willing to push the envelope, so to speak. But continuing, he also specializes, of course, in the orthopedic treatment disorders of children. And in addition to his clinical duties, Dr. Eberson is the program director of the Brown Orthopedic Surgery Residency. He believes that training the next generation of orthopedic surgeons is a tremendous responsibility and privilege. He has a passion for education, has helped develop the curriculum for educators for members of the Pediatric Orthopedic Society, and he's lectured on the topic to international audiences. We should note he's not alone in this. His wife, Denise, is a pediatrician. They have 3 sons. So he's busy with patients as a husband and father, and he's very active coaching flag football, soccer, and baseball. It's always nice to know something personal about our presenters. So I wanted to add that because his approach to surgery is very helpful. And of course, all of us who are listening today, we know how difficult it is with our pediatric patients. So with that introduction, it's a pleasure to welcome Dr. Eberson as he lectures on bloodless surgery, blood conservation in pediatrics. Dr. Eberson, we give the floor to you, so to speak.
Thank you so much. It's far too kind, but appreciated. Thank you all for allowing me to be a part of this amazing conference. I've learned a lot already just from this morning, so hopefully I can add something to the proceeding. So what I thought I would do is kind of touch base a little bit on our experience with our Jehovah's Witness patient population undergoing scoliosis surgery. Sorry about this guy. There we go. Okay, so just as a means of introduction, scoliosis is just a curvature of the spine, and about 1 to 3% of the adolescent population will have scoliosis. Our neuromuscular patients, cerebral palsy, spina bifida, et cetera, it's much higher. And this is major elective surgery. The average blood loss could be about 450 cc's, roughly about 45 cc's per spinal level fused. But for our neuromuscular patients, it could be even more dramatic, up to 70 or 80% of their blood volume. So trying to be innovative and creative at ways to preserve blood is very important in these patients. Sorry, guys. There we go. So when we talk about transfusions, there's kind of 2 situations we find ourselves in. We don't want to unnecessarily transfuse patients, either because we don't want to. So you've heard about all the complications, and you're very familiar with the complications of transfusions, including surgical site infections. But also in our Jehovah's Witness population, we can't give blood. They will not accept transfusion. So in our day-to-day standard surgical approach, we really strive not to require transfusion for these surgeries. And in fact, it has become increasingly rare for a idiopathic scoliosis patient to need a transfusion. But for our Jehovah's Witness patients, it's not an option. So what is our approach to blood conservation? Well, it starts in the preoperative period. And we'll go through this, but we want to maximize the patient. We want to discuss intraoperative options, tools, techniques to limit bleeding and help with clotting. We want to involve the appropriate colleagues. If you look at that little circle graph on the right, certainly the patient is in the center of the wheel. The surgeon is just one spoke. And there are a tremendous number of other folks who need to be participatory to give the best outcome for this patient. You know, Kevin and I work with our hematology contacts, or blood bank consultants, or anesthesiologists, et cetera, all centered on the patient in order to minimize the requirements for blood in this group. And then finally, we ask ourselves, are there other surgical options? There's always more than one way to fix a problem, or more than one surgery that could be helpful. And we try to balance the pros and cons of each approach. So when we talk about maximizing the patient, you've heard in far greater detail than I will provide this information this morning. But just for my orthopedist perspective, we first look to see whether they have anemia. We look for medications or supplements they could be taking that can cause bleeding. So anti-inflammatory medications, fixed fish oil, garlic, or anticoagulants. We also look for any evidence of underlying disease. Our neuromuscular patients, on many levels have a higher risk. Their clotting mechanisms are not as highly developed, and their surgeries are much more invasive. And so we know that we're going to have the potential for significant bleeding, but also kidney or GI disease can cause problems with clotting. So we do a lab evaluation, so they all get the standard blood count, but also iron studies, reticulocyte counts, B12 and folate levels, and coags. So what we've seen is not rarely even, patients will have no history of bleeding, no easy bruisability or bleeding gums when they brush their teeth or things like that, and may even have had surgery. But we've diagnosed several patients with von Willebrand's disease, which was previously not known. So we really try to go through this whole process to make sure there's not a subtle bleeding disorder. Spine surgery is very invasive, and their life up to that point may not have provided enough trauma that it brought this bleeding disorder to light. So making sure we kind of go through this whole process before the surgery is important. Okay. So the next step is we want to maximize the hemoglobin. So again, lab values are very important. You've heard a lot about this morning, so I won't belabor the point. But if they have a low ferritin or transferrin saturation, iron infusion, as you've just heard, can be extremely helpful. We use the Ganzoni formula, but there are others to determine the amount of iron you're going to give. And if we have at least 4 or 5 weeks, which we usually do for these surgeries, we can really optimize their hemoglobin levels. So the next possible option is, do we want to use erythropoietin? And for a standard idiopathic scoliosis patient, I would not do this. But for a Jehovah's Witness patient, we often consider this as a means to really maximize the hemoglobin. We aim for something in the high normal range. One of the things that we do intraoperatively that I'll talk about is we use tranexamic acid, and that is in combination with increased hemoglobin, potential risk factor for thrombotic events. So we have to balance all of these things as we try to come up with the best strategy for each individual patient. So the nutritional status is important. You've heard about this as well today. I'm not going to belabor this, but you're making sure their vitamin B and folate levels are normal. But the other thing that we think about is anything that we can do nutritionally to lower the risk of infection. When you look at someone who's had a spinal fusion and they have an infection that requires a surgery for debridement and cleaning, the bleeding from the cleaning surgery, the debridement surgery, is often substantially more than the bleeding from the original surgery. And since their hemoglobin is going to be lower and their iron stores are going to be a little depleted from the bleeding they have from the original surgery, an infection can really push this over the edge. So on many levels, it's important to prevent infection, but particularly on these patients where we really want to avoid blood products, be more helpful. And then we try to address, obviously, their other medical issues. If they have a chronic inflammatory disease or kidney disease, making sure those are maximized and dealing with the anemia that results. So when we have the discussion with the parents, most importantly, we do a risk assessment. And there are multiple papers that have been done and looking at risk factors for transfusion requirements during adolescent spine surgery. And in general, patients with many levels that need to be fused, so longer fusions, neuromuscular scoliosis, again, we've talked about that. It's a much larger surgery. Patients who need what are called osteotomies, and I'll talk about that in a minute. I'll show you what that is. All of those patients have a higher risk of bleeding. So if we know that ahead of time, we can stratify their risk. So we want to look to improve their intraoperative coagulation, but we also want to look at techniques to minimize bleeding. And again, we want to decrease their infection risk. So there are several factors that are important, right? So if we look at intraoperative options, there are several factors that are addressed by our anesthesia colleagues. Temperature control is very important, trying to avoid hypothermia, both for infection purposes and for coagulative purposes, very important. We maintain hypotensive anesthesia. The spinal cord can suffer injury if it's not well perfused, but keeping the blood pressure at a lower level, we usually shoot for a mean arterial pressure of 50 to 65, is very helpful in minimizing the ongoing bleeding from the muscles. Hemodilution is another technique that was popular years ago. Your blood is taken off and replaced either with a 3-to-1 ratio with crystalloid or 1-to-1 to colloid. And the concept is that you are bleeding more dilute blood, and then those cells are then transfused back to the patient. And some of our Jehovah's Witness patients will actually allow that as long as the circuit is kept closed. There are some potential side effects. Blindness in prone surgery has received a lot of kind of press recently. Very, very rare in children, but the thought is that that may be a factor. So we don't really do that as much anymore. Epidural anesthesia with the venodilation also keeps the mean arterial pressure low and prevents ongoing bleeding. Rector spinae blocks will use a lidocaine with epinephrine, and that can actually control bleeding somewhat. We do use TXA very frequently, and there's really no agreed upon dosing regimen in the literature. They're talking with colleagues at other institutions. It's all across the board. So usually we'll use a bolus dose of either 10 or 20 milligrams per kilogram, and then a continuous drip. And that really helps minimize ongoing bleeding. There are some concerns, again, of thrombotic events. We've seen that in our hospital, rarely in adults. We've never seen this in children, but it's something that we try to be aware of. Apologize, Guy. And then finally, DDAVP for our patients with von Willebrand's disease can be helpful. So moving on. So some other intraoperative options. So self-salvage. This is a very helpful technique. We use this in all of our scoliosis patients, and then it is tolerated by Jehovah's Witness patients who require a closed circuit between the body and the transfusion that's coming back. And essentially, we will suction any ongoing losses. It gets washed by the machine and it's given back to the patient. So you basically have a unit of blood with a high hematocrit. And my experience is about 1/3 of our losses can actually be returned to the patient. So that could be a very helpful technique. And finally, surgical technique is important. There are several options that we have available to us to help with bleeding. So spray-on collagen thrombin products are helpful. Fibrin sealant is helpful. So one of the things we do with spine surgery is we put screws into the bones, and the bones can bleed substantially. And if we do 20 screws and you're losing 10 cc's per screw, that winds up being a substantial blood loss. So we have injectable fibrin sealants that actually plug the holes where the screws go in, and that's been tremendously valuable to us. The U.S. military developed kaolin soaked sponges, and packing a wound with those can be helpful. And the Aquamantis has also revolutionized our blood management. So this, instead of using electric cautery, if you look at the two prong tips here, heated water basically is jetted between them, and it's a bipolar sealant. So it actually is causing thermal damage to the collagen fibers in the vessels, so they shrink and permanently seal. And it's less pinpoint maybe than the electric cautery we use. So for massive bleeding, particularly with our neuromuscular patients, you can easily control the bleeding with minimal tissue damage. So that's been a game changer. So when we look at our strategies, there are surgical technique strategies that we can do to limit bleeding. So one thing that I always do in our Jehovah's Witness patients or our large neuromuscular patients is we make sure we have a skilled assistant. This is not the case to teach a junior resident how to do the surgery. I'll do this with a junior partner or a fellow, and that's enormously helpful at very kind of effectively exposing the spine and minimizing the bleeding. And that's where most of the bleeding comes from. Neuromonitoring is important for spine surgery. And we need a skilled neuromonitoring technician. If they are uncomfortable with our spinal cord signals and they feel that there could be something going on, the first move usually is to raise the blood pressure, which increases bleeding. So trying to make sure the team all understands our priorities and is very comfortable in a hypotensive environment is key. Something else I find very helpful for our large cases, for our neuromuscular cases, is I will expose the lumbar spine and put all of my instrumentation, my screws into lumbar spine, and I will pack it to minimize bleeding. And then I will open the top of the spine and do that rather than opening a huge incision and allowing this ongoing bleeding to occur. So different ways of exposing or approaching the patient can be helpful to minimize bleeding. And then finally, for our Jehovah's Witness patients, particularly, frequent checkpoints with potential to abandon the procedure have to be done. So as we do our exposure, we look at the end of that and what our blood loss has been. We look at the H&H. Spectrophotometry can be very helpful for kind of a continuous monitoring. But essentially, you're trying to find your stopping points, and those are helpful to identify ahead of time, where you'd say, well, if we've lost a lot of blood up to this point, it probably is not a good idea to continue, and we should stop, and then we can complete this as a second stage. So knowing that and deciding that ahead of time is very important. So large curves that are stiff often increase blood loss, and there are several ways to handle that. So this is the osteotomies I mentioned earlier. If you look at your spine, we basically take out the joints and the ligaments between the bones, and that will substantially loosen things. This is what it looks like from the back, you have your joints here, and we actually remove bone here. So the combination of cutting the bone and epidural veins can lead to a fair amount of bleeding. So this is a very helpful technique, but we have other strategies that we sometimes use. So one thing that I found to be very helpful is preoperative traction. And we can use that both before surgery, during surgery, and there's some other techniques that I'll talk as well. Secondly, we don't have to shoot for perfect. If you look at this patient, this is a 148-degree curve in a patient with severe dystonia. This is a horrible deformity, and we didn't have to get this down to zero. The X-ray on the right is his intraoperative X-ray with a limited number of implants and some intraoperative traction. We're able to obtain a nice balanced spine and really limit the amount of struggle, and by struggle, limit the amount of bleeding during the case. Other times the case is so monumental, we do it in a staged fashion. Right, so this is traction. We have a custom wheelchair and walker apparatus. We make them in different sizes for different height kids. This is from a paper that we had written a few years ago. And essentially, we gradually increase the weight so that the deformity is slowly stretched out over time. This allows a much more simplified procedure and often eliminates the need to do osteotomies. And this is intraoperative traction. Can't really see because she's got a lot of hair. She has her halo ring on here connected to the top of the table with weight. And we use skin tape in this case to have some weight on the bottom of the table. And by just doing our exposure and working with the patient in traction, hour after hour, we've noticed that we get slow, gradual correction. And again, we can eliminate the need to do a lot of our osteotomy work. Temporary internal distractions, another little trick. And I put this picture in for two reasons. One, I think you can get a sense from looking at this how massive the exposure is for a spine surgery. And this is all muscle, which all bleeds. So you can kind of see what some of our problem is. But basically, you have this big curve, and we put two short temporary rods in with it connected to another rod. And every few minutes, we just keep stretching. So we'll get a gradual correction. And then we'll put our final rod in. And this is what it looks like in a child with cerebral palsy. You'll have a screw or a hook in the pelvis. You can't really see under this muscle. We have some hooks on the ribs, and slowly spreading these rods apart until we get what we need. And we drop our permanent rods in on that side, we put a rod on the other side. And we've been able to do this by minimizing the amount of osteotomies and by quickly getting the correction that we need. So sometimes we do this as a stage procedure, and this could be a planned or unplanned, as we mentioned before. The nice thing about staging, we can use erythropoietin, iron, and nutritional management between the stages to really get the patient optimized. We can also do traction between the stages. And so the key thing that has to happen really with the patient, surgeon, and the family is a discussion of the goals. What are we really trying to accomplish? Is this a curve that we need to make perfectly straight? Are there other ways to do it? What are the risks and benefits of being more or less surgically aggressive? And what is our tolerance for a staged procedure? And by factoring all of those things into an individualized plan, we can do what's right for the patient. So what's the protocol at our institution? So we identify a high-risk patient. And for all of our scoliosis patients, we use TXA, we use Cell Saver, we use the Aqua Mantis, and we use some other techniques. But for our high-risk patients, either medically high risk, like a neuromuscular patient or Jehovah's Witness patient, we liberally involve our transfusion-free medicine service. And this is where Kevin and I have worked together. Our hematologists are really a crucial part of the team. We have a complex perioperative program for our anesthesia department. And we get other consultants as needed, nutrition, pulmonary, GI, et cetera. The goal here is identifying every need of the patient and meeting them beforehand, because remember, this is elective surgery. When we schedule these surgeries, they're scheduled with a skilled assistant, as I mentioned, but also part of our high-risk anesthesia team. All of our anesthesiologists are very good, but some excel in different areas. And there's a core group who are excellent in managing these patients intraoperatively. Once we've done that, we have our discussion with the family. Occasionally, we involve their clergy, particularly in the case of Jehovah's Witness patient, or the transfusion-free medical service, and we really lay out what our goals are for the procedure. Occasionally, there could be a surgery, and we've had cases where there clearly would be such a dramatic. I had a patient with scoliosis who had an enormous hemangioma in all of their paraspinal muscles, and there was absolutely zero way to safely operate on this child without catastrophic blood loss, and they would not survive without a transfusion. So having those conversations beforehand and knowing when to say no is very important. But what we found in rare cases that occurs, in most cases, we can work with the family and their own individual beliefs and come up with a plan that makes everyone satisfied and makes us feel that we're going to do the right thing for the patient. So this is a case example. So this is a 13-year-old girl who was sent to me for scoliosis. She had seen a previous surgeon, but didn't follow up, and mom works for a neurosurgeon who thought she should see somebody. She's otherwise healthy, but the family, they are Jehovah's Witness family, so transfusion is off the table completely. So we got Kevin involved, hematology involved, and we had a family discussion about what their specific beliefs were. So no blood products, but cell saver was okay, erythropoietin, tranexamic acid, and iron were all okay. And we also discussed, this was not a horrible curve, but we talked about staging options or possible traction. So her blood work was not terrible. She was a hemoglobin in the low normal range. Platelets were normal. She also had sickle cell trait with no known history of any issues. Her ferritin and iron were kind of low normal. Saturation was 18%. Iron binding was right in the middle, and her folate was also low normal. So with all that information, with the assistance of our hematology colleagues, we received IV iron over multiple doses and folate, and 10,000 units of EPO IV. Her pre-op hemoglobin at that point was raised to 13.2. So we had discussion with our blood bank and hematology and anesthesia colleagues about the potential risks of cell saver leading to sickling with sickle cell trait. And it was felt that the risk was very low, and there's good support in the literature for using cell saver in these patients. So that was good. And then we talked with anesthesia, hematology about assessing the patient's thrombosis risk and customizing the dose of tranexamic acid to avoid thrombotic events. The family. All right, so a surgical plan. So we discussed preoperative traction. We discussed the different checkpoints, and this is important for us. We discussed really not so much in a legal sense, the Rhode Island law, but it's always important. And with all of my patients, we explain that, you know, while we have to respect their beliefs, they have to kind of respect ours in a similar sense. And, you know, in cases of life-threatening immediate hemorrhage in the operating room, a transfusion would be a possibility. Most patients understand that, but we also clarify that in the post-operative period, we would have to use other tools and techniques to raise the hemoglobin. So we just try to get a sense. This patient is under 14, so technically, you know, we can make decisions for. In Rhode Island, children over 14, if they are allowed to tell you that they don't want blood, and you have to respect that just as if they were an adult. So probably understanding what that is in your state is very important. So this family chose traction. Again, the feeling was it would be an easier, quicker correction, fewer implants. We had a second attending surgeon involved, an experienced anesthesia neuromonitoring team. She underwent a spinal fusion from T2 to L3. So we do some math beforehand. So the total blood volume was roughly 4,150 cc's. And so our blood loss was 300 cc's, which is about 7% of her blood volume. And so we kind of play around with a bunch of different formulas to predict how much blood is too much. There's the maximum allowable blood loss before transfusion, and you can look at what the child's blood volume is, their starting hematocrit, what your minimum accepted hematocrit is. So if we plug some numbers in there and say, boy, I wouldn't want her to be much lower than 21, even though I wouldn't transfuse any patient for a hemoglobin of 21. In a Jehovah's Witness patient, that would be a stopping point. So that's a fairly significant blood loss. The other way we look at things is 20% of blood volume is responsible for clinical shock. So if we get to that point, that's about 800 cc's. So keeping the blood loss at 300 cc's, you know, made this a very reasonable surgery. I use intrathecal morphine for pain management postoperatively. This also keeps the blood pressure at a reasonable level postoperatively. If you think back to that clinical photo with all those muscle edges exposed, there is the potential for significant ongoing bleeding. And so trying to minimize that is very important as well. So in summary, blood conservation is a team sport and communication is key. With these patients, we have to plan ahead, be flexible, and we have to assemble a great supporting crew. So that's my supporting crew. Oh, and these are in the, this should be available. These are some references.
Thank you very much, Dr. Eberson. That was a remarkable presentation, and to actually see that you handle such complex surgeries and to be able to do it successfully, that is a great feat. And so there will be more questions that we would like to discuss on. And so we would actually go into the questions. And yeah, perhaps maybe since you're on, I would probably ask, right, like you did mention about being careful about, if it's neuromuscular and as compared to the regular scoliosis. And so that would require much more preparation. And do you need to sometimes, in certain cases, would you discuss further with the hematologist or something like that?
Oh, absolutely. I think that, the biggest issue is that those neuromuscular patients are so medically complex. It's never just a simple thing. And then technically, it's like any other patient with a chronic disease. So they often have an anemia of chronic disease. They're clotting. It's interesting. You can look at their coag studies. We used to do bleeding times on these patients as well, and they were routinely abnormal. And so they have evidence of platelet dysfunction. And not that it's, it's not a guarantee, but it's more of a certainty those patients are going to require potentially a transfusion. So I think knowing that, trying to get them prepared in a way that we minimize the need for a transfusion or as few units of blood as possible is very important. But it's their overall health is often not good. And this is one of the problems with those patients is that they're very complex, and there are some patients that probably shouldn't have surgery. And that's a whole different conversation. But the ethics of putting a child through a procedure that might require massive transfusion and questionable long-term value for their overall life is difficult. So, but we to answer your question, we do things. It was very popular for years for patients' families then that they would donate blood for the patient and they would feel like they were contributing. But I think that kind of almost makes you use it, right? If you have blood donated specifically, you're going to want to use it. So I kind of dissuade the family from doing that. And we try to lean towards maybe some of the techniques that we mentioned to try to avoid a transfusion.
Could I ask a question as well?
Yeah.
Craig, thank you. Excellent. A couple of questions came up. One of the colleagues wanted to get your thoughts on topical TXA versus IV. So I'll let you comment on that, and then I have one other question.
So it's a great question. There's our total joint colleagues use that fairly liberally and are pretty happy with it. I have not. I've played around with it. I mean, we've trialed it at our institution. I find it a little bit unwieldy. I think with a really large surface area of muscle like we have in spine surgery, it becomes somewhat difficult. I personally prefer the intravenous because I think that it just works better. It's hard to kind of constantly keep spraying a enormous surface area. But sure, that's used very frequently in our total knee and total hip patients.
Good, thank you. And then secondly, could you speak a little bit more, I guess, from the standpoint of staging, because staging and then also not striving for perfection?
Yeah, that's also a great question. So, staging, can be thought of in a couple of ways. So, for example, it was very common in the past, right, to do neuromuscular scoliosis, a child with cerebral palsy, for example, like that picture I showed. We would do a release in the front of the spine. We'd go in, we take out the discs and cut the ligaments in the front of the spine, and then go to the back and put in our screws and rods and such. So that often can be done several weeks apart, right? So that would be one potential. So one of the things that we realized that's an enormous stress on the patient's system. Those are two big surgeries. So with osteotomies, and there's many other osteotomies, I didn't want to get into that for this talk, but that we do remove cutting segments of bone and loosening up the spine. So that's allowed us to avoid having to do the front part of the surgery. But what it has done is caused a bloodier surgery in the back, right? So when I mentioned, my approach, so if we're going to fuse the patient, their thoracic, lumbar, and their sacrum together, I'm going to expose the lumbosacral spine, put my screws in, and just kind of see what our blood loss looks like. If we're doing okay, we pack that wound and I close it with towel clips. So it really is like a closed wound and the bleeding is minimal. And then I can expose the thoracic spine, which is different than what we used to do, which was do the whole thing and just keep going. And there was a ton of ongoing bleeding. And so we've had these patients, before the aqua mantis really, and we've had some patients who every every part of their muscle you touch bleeds, and it could be pretty frightening. So if we felt that we couldn't kind of get going there, we would basically done what we could, pack the wound, or close the wound up, and then, resuscitate the patient and make plans to do the second stage at a different time. I've not had to do that, but I think, again, building these checkpoints into your plan, right? You don't want to get to a point of no return where you have no choice but to continue. So building in checkpoints is very helpful.
Thank you. Very, very helpful. And I guess if I might, one final question. So in the cases that we've had, the importance of, I've appreciated, because pediatrics, everyone wants to give blood no matter what, and everyone's very skittish, understandably so. Your approach, though, has been a bit different in that you're willing to talk to the family about it and push the envelope. Can you speak to that? And that's my final question. Thank you.
That's a great question. I think that it is difficult, and the knee-jerk reaction is, well, this is a surgery that's involved, and this patient might need blood, and it's just I'm going to give them blood, and if I can't give them blood, I'm just not going to do it, right? I think being a staff at a children's hospital, we have a little bit of more of a family-centered approach, and colleagues of mine like Kevin and our hematology group, really everyone involved, really are willing to come together. And that's the key thing, right? So I think if you have a team and you have support, then you can approach the family. And I think as long as they understand, Kevin, I found, I think you probably have as well, the family are willing to work with you. They appreciate that you're willing to work with them, and there are cases that, are really challenging, but I think that's the key, right? And I think that, again, you can look at your case and look at where you're trying to get and say, you know what? And you had asked about maybe not doing as much. These children with neuromuscular scoliosis is a perfect example. If you make their shoulders and their pelvis level, they can sit comfortably, right? They're still going to have a big curve, but they can sit comfortably. They can breathe. All the goals of your surgery are met without doing some huge thing. And at meetings, we like to impress our colleagues by showing how many screws we put in, how straight the spine is. Families are not impressed, right? So if their goal is sitting comfortably, we don't have to do a big, massive surgery. Now, there are some downsides to that. If you weigh it against the blood risk and everything else, and this is why, the family, it's amazing what our goals are, Kevin, and what their goals are often different. And so I think if you understand what their goals are, it might be far, often it's simpler than you initially thought.
Excellent. Thank you. Thank you so much.
Thank you very much, Dr. Eberson. So that's really great. And to think that, when you actually do the complex surgery and yet basically, respect patients, the family wishes and all. And well, sometimes we do compare with certain pediatric patients who are not undergoing surgery but have anemia and being transfused. So yeah, your example is really amazing. So we can use that, to actually help many others as well. Thanks. All right, so we can go.
Can I say something, please?
Yes. Sure.
Yes. So Eberson, thanks for a very wonderful presentation and a great work that you're doing. Just wondering, from your patients that you've been managing without blood compared to the ones that have had transfusion, have you seen any differences in outcomes, duration of stay, wound healing, and long-term recovery between the two groups in your practice?
Good question. I would say, the length of stay, really the short answer is no. And I don't mean that in a negative comparative way. I think that those patients do just as well. The added benefit of undergoing a blood conservation type of technique. The length of stay for an idiopathic scoliosis patient now is about 3 days, which is pretty quick, but they do very well. And I think that the benefit to having this technique or having this work we've had to do for the Jehovah's Witness patient is that it carries over. So I might lose 300 cc's in this case, but I might lose 400 cc's in the next case. In other words, blood loss across the board has gone down because a lot of these techniques are applicable even if they're not a Jehovah's Witness family. So I think that's the big lesson. We had patients auto-donate 2 units of their own blood before surgery. I haven't done that in about 15 years. Family members would donate for patients. I haven't done that for a long time. And it's really shocking when an idiopathic patient gets a transfusion. We just don't see it anymore. So I think that working with Kevin and the team on our Jehovah's Witness patients has carried over and really resulted in better care for all of our patients.
Wonderful. Thank you.
Thank you. Yes, very true indeed. The principles that we learn in these bloodless patients actually benefits everybody, right? Yes. Okay. Right. So we have a couple of other questions for some of our speakers. I noticed one early on. Actually, it's a question to Dr. Sharmini. Please, can you give more explanation on the single unit transfusion? Are you referring to blood fractions? And yeah, perhaps you can also comment as to, like you mentioned, it should be the last resort, right? Thank you. You're muted, Dr. Sharmini.
Okay, can you hear me? Can you hear me, Ananthi? Yes, all right. So I think in obstetrics, we know that it's most of the time a bloody situation. And we try all measures to reduce bleeding when the patient is in labor or in the theater for a cesarean section. And when I talk about the single unit policy, I mean if the patient is really hypotensive, tachycardic, and has lost more than a liter of blood, and that is when you can resort to just using first 1 unit of blood. And then if she improves further, you can just top her up by using IV iron, which is what we practice in our center. And if the patient herself has lost blood, but her vital sign parameters are within normal, then we don't resort to giving blood at all. So we just straight away improve her hemoglobin by giving her IV iron. Okay.
Yes, thank you. Yes, you're right.
Can I add something to that question, please?
Yes.
So regards to this, so even if the patient is hemodynamically stable from this principle, you still go ahead and give the 1 unit of iron, blood, I mean to say?
No, we don't. We don't.
Okay.
But if her hemoglobin has dropped, then we would give her iron after, immediately after that.
Even if there's no clinical manifestation or evidence of a consequence of that drop of hemoglobin?
You must remember that in obstetrics, it's different because during the puerperium, they also have blood loss and they practice breastfeeding. So we need to improve the situation for the mother before she goes home. And we try to keep her comfortable with whatever hemoglobin she started with.
Thank you. Yes, and also perhaps in the future, I'm not sure, like perhaps in Malaysia, we don't use so much of cell salvage yet, but perhaps in future, we may have that more available. And in that sense, we can also reduce blood loss, or at least the blood that is lost to the surgeon is not lost to the patient. Yes, thank you, Dr. Sharmini. And I have
one other.
Sorry.
I'm sorry. Might I ask one other question of Dr. Sharmini, and appreciate your presentation. So, because we're associated with the primary obstetrical care cases here. Prior to procedure, when the woman first presents, I'm assuming you consider IV iron at that point as well, as far as building up prior to delivery and such.
Oh, if we see her early in the antenatal period and there's an iron deficiency, we resort to oral iron first. And if she's nearer term, then we need a quick correction of her anemia, then we would resort to IV iron. So it's always the first line is oral iron. And if the need is urgent, then we would resort to IV iron.
Okay, thank you.
You're welcome.
Thank you. All right, so we have a question on oral iron. So I would actually ask our panelists, Prof. Vernon Low, so he can answer that. It is basically talking about the use of perhaps when we have an oral iron, does caffeine-free coffee or non-caffeinated tea have the same effect? And do they also affect absorption of iron? I would like to invite Prof. Vernon Low. Would you
Thanks
like
very
to
much.
please? Thank you.
Thanks very much, Ananti. I'm just trying to get my video going. There we are. And thanks also for inviting me to this wonderful session. I so enjoyed listening to the three speakers. So thank you very much. I think it's a very interesting question, the effect of different dietary agents on iron absorption. And the one of coffee and tea is always particularly interesting, but I think one should remember that the factors that cause the decrease in iron absorption are polyphenols, and there are different types of polyphenols, phenols, flavonoids in tea, for instance, and other types of polyphenols in coffee, which would be present both in decaffeinated and caffeinated coffee. So both of them will affect your iron absorption. And sort of loosely, one can say coffee would decrease iron absorption by about 40%, and tea somewhere between 60 and 90%, depending on the type of tea that you look at. So it's quite significant. And for that reason, I think it's important to keep your tea for tea time and the coffee as well, and not with your iron supplement, because it is likely to be poorly absorbed. Thank you.
Thank you, Prof. Low. And so that gives us some insight, and we should keep tea and coffee for those times and not together with our iron tablets, right? Okay, we also have our maternal fetal medicine specialist from Malaysia, and perhaps maybe Dr. Carol can comment on something about the importance of actually optimizing haematocrit as well as iron during pregnancy, and the effect it would have not only on mother but on the fetus itself. Thank you.
Thank you, Dr. Ananti. Yes, iron is important, or correction of maternal anemia is essential, not just to ensure safeguard maternal health, but also for neonatal as well. For example, to prevent the neonatal anemia, to prevent intrauterine growth restrictions, small for gestational age, preterm labor, and in the long run to reduce neonatal morbidity and mortality. So yes, it is not just for the mother's health per se, but also for the neonatal health as such. So it's essential. So iron is important and indispensable for every cells in the body. And we are unique in obstetric patients, so we have babies to be concerned of as well. So it's not just mother to prevent, postpartum hemorrhage or even lactation, as what Dr. Sharmini had mentioned before. So yeah, it's very important to correct anemia.
Thank you very much. So in that sense, it's kind of a preemptive for the fetus and the future baby as well, right? And to prevent neonatal anemia and the bad effects of it. Yes, thank you. I think there's also a question for Dr. Eberson. Yes, so here, thank you, Dr. Eberson, for your exceptional demonstration, especially scoliosis for JW patient. What is your take on cell salvage as putting prime on the list of blood conservation modalities for JW patients? Because I think salvaging the blood from shallow surgical field needs more caution or technique.
So the question is, how do we use cell salvage as part of our normal approach? Or the technique specifically? Was that so to make sure I understand the question? Yeah. Okay. Yeah, so I would agree. So when we use the cell saver, it is difficult. It is a shallow field. That is 100% true. And so you have to be very cautious. We usually have 2 suction setups on our surgical field. We have one non-cell saver and one cell saver. So when we do irrigation, or that kind of thing, or we do pulsatile lavage, cleaning, we'll use their standard suction, but the entire rest of the case we're using cell saver, and it takes an assistant who understands conceptually what you're going to do, to make sure that all the ongoing losses are sucked up. So I mentioned putting in pedicle screws. We drill little holes in the screw and then blood comes out, right? And the suction tip has to be right there, and then we'll put our fibrin sealant in and stop that. So it's interesting. There are cases we do where at the end of the case, we don't have enough blood yet in the cell saver to return to the patient, but that's actually a good thing. That means we didn't lose too much. So it takes vigilance to use that in a spine case, and make sure that you maximize the return for the patient.
Thank you, Dr. Eberson. Sorry. Okay, there's a question on, will you advise the use of IV iron as a treatment plan for 4-year-old sickle cell patient with a HB of 2.5 who is having an attack? Perhaps any of our hematologists would want to answer that.
Again, please.
Okay, the question was, would you advise the use of IV iron as the treatment plan for a 4-year-old sickle cell patient with a HB of 2.5 milligram per deciliter who is having an attack?
Certainly no. Not many physicians or pediatricians will accept that because of the highly controversial nature of adding iron to patients who are living with sickle cell anemia, in that the problem with them is not that they don't have iron, but a chronic disorder and a complex mechanism. There's iron in the body, but they're not well utilized. And because they are constantly hemolyzing, most of the iron from the red cells that have been hemolyzed are also sequestered somewhere in the body, in the reticular endothelial system. So adding more, there's a great fear of tipping them over to iron overload. However, there may be some cases, isolated as it were, that can make
I think we lost his connection.
I think we can't hear, right? Dr. Inyama?
Can I say something there?
Yes.
Pepsid in there, that will give us a clear picture of the iron parameters in this patient to say, yes, this one can benefit without harm or tipping the patient over to iron overload at such an early age. So the answer is no, but with some few exceptions.
Thank you, Dr. Inyama. And Dr. Usop, do you want to say anything?
Absolutely, thank you very much. So I'm not a hematologist, but I'd like to bring in another viewpoint, which is gaining ground now. So the idea that a patient, sickle cell patient, already has a lot of iron, yes, but that iron might not be available for use by the body. It might be sequestered in various reticular endothelial system cells, and therefore not useful. So there is a trend now to think about, to actually check for iron deficiency in sicklers. And it has been found that some of those sicklers are iron deficient. As a matter of fact, the sicklers that have excess iron are those who are repeatedly transfused. For patients in no blood patients, they wouldn't have excess iron. They often have iron deficiency. And as a friend of hematologists, but a surgeon, I would say yes, we can give IV iron to such patients. We can actually check their ferritin levels and be sure. But even if we cannot check, think about it. How many physicians hesitate to transfuse that patient? A lot of people will transfuse 4 or 5 units of blood, and each of those units of blood contains 200 milligrams of iron, like Dr. Parampalam showed us. So if they don't hesitate, and as a matter of fact, very likely, the only thing the body uses in that blood is the iron, because the body recognizes that that blood is foreign material. So it's going to throw out everything, but it can use the iron, which is perhaps why some transfused patients manage to increase their hemoglobin, because the body makes use of that iron in the blood. But the body is smart enough to know that the rest is foreign material, so it will throw it out. So if you wouldn't hesitate to transfuse this patient with 2.5 hemoglobin, why should you hesitate to give that patient the same quantity of iron if you're going to give 4 units of blood? So you can also give 800 milligrams of iron. Why not? And add the adjuncts. You need to add the folic acid, vitamin B12, vitamin C, and even erythropoietin. And you can get that hemoglobin up. And don't forget the diet, because I think when we were with the Asian Society for Patient Blood Management, we actually brought on a sickle cell patient who works in our hospital, and she said she takes up her hemoglobin just by diet. And I think Dr. Nyama is one of her doctors, so he can testify that they keep telling her to stop whatever she's doing, because the hemoglobin comes up, she comes up to like 13, 14 grams per dl. So Dr. Nyama will say, stop whatever you're doing. And I say, no, she shouldn't stop. She's okay, she feels all right. It's not causing, it wouldn't cause, they're afraid that it will cause maybe sludging of the blood or something. But those things, deep vein thrombosis, they're actually caused by blood transfusion, not by the normal, by the patient's own blood. Sorry if I took your time. Thank you. Surgeons talk too much.
Yeah, although I can't remember telling any patient to stop or seeing someone with sickle cell with hemoglobin of 13, 14. All what Nati said is correct, but let us take note that I know there are about 4 studies that have been done, even here in Nigeria, trying to assess the iron status of patients who are living with sickle cell anemia. True, it is correct that if we give iron and then give erythropoietin to patients with sickle cell anemia, you can drive what is in there in that patient to start moving using whatever has been blocking the non-usage of iron sequestered in the reticular endothelial system. But the 4 studies that I know that have been done, unfortunately, did not go all out to look at the things that could make a very accurate interpretation of the iron status of these patients. We are still waiting for a situation where a grant will be available for a good clinical trial will be conducted, whereby some patients with sickle cell anemia will receive iron after a good workup, iron workup has been done, and some have not, and then see what the outcome and at what level we'll say this one is at the threshold of being tipped over into iron overload and things like that. We can say this is the efficacy threshold and safety threshold and things like that. However, when desperate, we have given iron. We do give iron. I do not remember a patient telling our sickle cell patient to stop taking iron, as Dr. Sarah said. But I do agree that in spite of all this, being careful, and waiting for clinical trial, we still give iron to some patients who are living with sickle cell anemia, and they come out clinically doing a lot better. So that in part covers what Dr. Zora said.
Yeah, let me describe the patient so you can sue her for defamation. She's a sickle cell patient who has had 2 bloodless cesarean sections. She's not a Jehovah's Witness, but she doesn't like blood transfusion. She has had bilateral hip replacements. And each time, of course, I think she had some iron, but she said she mostly built up by diet, and that her blood level goes up to 13. The hematologist said, no, she's going to have some clotting that she should stop. So maybe it wasn't you, actually. Maybe it was the other hematologist.
I think in which case, are we even thinking of the hematologists or obstetricians or gynecologists who do not know? This is something that should be discussed in the background, in my opinion. Thank you.
Thank you very much. Yes, so it's also interesting in recent studies, they do mention to, in the sense of how to also reduce the events of sickle cell crisis and all, and the promotion of the use of hydroxyurea, which is actually very useful. And so we can also learn further about that. I think I would also like to invite Dr. John Friedman. He's a professor of hematology and also from Canada, right? So maybe Prof. Friedman, would you like to give any comments from our session today?
Thank you. Other than the fact that I really enjoyed the sessions, I don't have any further comment. Thank you.
Thank you very much. And yes, so if we don't...
Dr. Bunch has raised her hand. I guess she wanted to speak.
Prof. Vernon Low, would you have a comment?
Thank you, Anante. Just two quick comments. I think we should be aware of excessive use of erythropoietin. I think erythropoietin is a very, very valuable adjunct, especially in patients who for other reasons cannot take blood or have reasons not to want to have blood transfusions. But the reality is that there are black box warnings about venous thromboembolism, stroke, etc., with erythropoietin use. And those of us who've worked with it long enough have seen that. So I think a patient should be very well counseled. If you're going to exceed the normal limits, which one might have to do, and make sure that your patient's informed consent includes an understanding of the risks that are there. Just like we would explain risks for blood transfusion, one should also, I think, make sure patients are aware of that risk. The second comment, if I may, is just with regards the use of ferrous sulfate. I think there's some great studies, and I think one colleague has also mentioned this about using ferrous sulfate in a slightly different way, alternate day dosing in particular, which has been found to be more tolerable and probably just as well, if not better, absorbed. And there's been studies in Blood and in Lancet Hematology and a number of others that have shown that that's probably a better way. And I personally never give ferrous sulfate more than once a day anymore. I used to do that in the past, but now it would be maximum once a day, but ideally every Monday, Wednesday, Friday would be my typical schedule. That first dose that you take increases your hepcidin levels for 48 hours. So that's the reason why it doesn't work as well, but it just increases side effects. Thanks.
Thank you. Yeah, so that is actually good insight as well. And so it is true that I think nowadays also it is encouraged that we probably dose oral iron, especially the traditional ones, perhaps every other day, like what you mentioned. Thank you. And maybe just I will combine a couple of questions. There's this question. Have you seen EPO resistance or antibodies? And what would you do in a scenario with a bloodless patient? Anyone is free to answer. Yes.
I think fortunately the problem with anti-EPO antibodies become extremely rare. I think those problems date from about 16, 17 years ago actually 20 years ago now. And a lot of things have been changed. And I must say, I've never seen any problems for the last 18 years. The last time we've seen such problems was in the early 2000s. And I think the formulations are now such that although it's not impossible, it is extremely, extremely rare. If one would run into it, of course, then one would look at managing with every possible patient blood management technique that you have. But I would then be careful with further exposure to EPO.
Thank you very much for the comment. And maybe one comment I can probably make is that earlier Dr. Sharmini mentioned that there is a need for patient education. And yeah, we got encouragement from our colleagues from SABM, BMSS, and ASPBM. And so, yeah, our Malaysian Society for Patient Blood Management, we have been doing a few patient education videos. And so in hope that we would actually empower patients as well, because they have a right to decide what happens to their body. And so when they are educated and empowered, then they would be able to request their clinicians and the team treating them to give them the best care that they want. Right. So we're moving on to the next session. But before that, if I could ask Natalie to play a couple of videos that is related to bloodless medicine and surgery. Thank you.
People feel that if you don't receive blood, you're getting alternative care and the care is not as good. That's the myth and that's the misconception. There are times that giving patients blood is more dangerous than not giving it to them. We have an armamentarium between the medical breakthroughs, the surgical techniques, and the anesthetic techniques that we use today enable us to treat patients in a safe environment without the use of blood transfusion. It's better medicine if one can be treated without the use of blood transfusions when you avoid all of those potential complications, both infectious and non-infectious. It is, so to speak, the gold standard, and hopefully it will become the standard of care. My name is Dr. Richard Slatkin. I am the Director of Bloodless Medicine and Surgery at the Maimonides Medical Center. My area of specialty is Obstetrics and Gynaecology, and I'm board certified in 1982. My medical training did my pre-med at New York University, medical school in the University of Bologna in Italy. My professional career started with a rotating internship at Long Island College Hospital and residency in obstetrics and gynecology at the Brookdale Hospital Medical Center. I'm also a board-eligible ophthalmologist, which I did in between residencies. Between my internship and my residencies, I'm also an ophthalmologist. My particular area of interest started about 25 years ago, dealing with a Jehovah's Witness patient who most people know will refuse blood. And it was such a uplifting, rewarding experience. I decided to pursue that area. And over the next 25 years, I've developed techniques and skills and expertise that I hope to teach other people in the future. And it's my particular area of expertise, something that I'm very passionate about. Current trend in the field of bloodless medicine surgery is to try to reduce and eliminate the use of transfusions. The cost of blood is very, very expensive. The number of people who are available to be donors today is getting less and less. And through the years of research and clinical experience, we've realized that there are infectious and non-infectious complications of blood, and so we try to avoid those. This all really started in the early 80s when AIDS became the epidemic, that the medical community started to realize that there are complications of the use of transfusion. And from that really developed a subspecialty unto itself. And the Joint Commission is very concerned about complications of medications and blood. And so the current trend is to try to have a blood management strategy program within hospitals to reduce and eliminate the use of blood where it's possible. There are some wonderful breakthroughs that have happened in the last 20 years. Breakthroughs in technology, breakthroughs in medication, and breakthroughs in techniques. Some of the medications are, we call them wonder drugs, where they stimulate the bone marrow to produce blood cells much faster to help us avoid using blood. The technologies that are available today, we have second and third generation cell savers, which while you're operating, we can actually suction the blood, filter that blood, and give it back to the patient in a closed circuit so the patient doesn't require getting allogeneic blood transfusions. The third area of breakthrough has been in anesthetic techniques, the kind of anesthetic agents that you use and the type of hemodilutional anesthesia and anesthesia. We can't do the kind of surgery that we do today without the expertise of the new breakthroughs in anesthetics. And fourthly and lastly, the technology involved in the surgical instruments that we use, areas like laparoscopy and robotic surgery, minimally invasive surgery. These are all innovations which are helping us to reduce the size of incisions and the amount of blood loss during surgery. Patients recuperate faster and require less blood and are out of the hospital sooner. So those areas that are coming in the last 20 years between the medicines and the anesthesia and the new technology, that really helps us to have these programs and treat patients without the use of blood. What patients know about me and my practice is that I and my staff will treat all patients with caring, with kindness, with dignity, and a sense of professionalism. That when the patient walks out the door, they know that it's not only health cure, but it's also health care.
Thank you for the video, Natalie. Yes, so thank you everybody, but we will not yet end. We still have the next session. And so first of all, would like to thank all the speakers, panelists, attendees, or everyone supporting the program. And before we move on, I would like to introduce Rita Schwab. She's actually a very experienced mentor and also a very experienced advocate and managing the bloodless medicine and surgery program. And so she will introduce the next session with our next speaker, the industry session. Rita, please.
Thank you so much, Ananthi. I want to say, first of all, that this has been a fabulous week so far, hasn't it? It's a meeting of the minds. It's an opportunity for people from all over the world to get together and learn from one another and enhance their knowledge. We're so appreciative to the Society for Bloodless Medicine and Surgery for making this possible. One of the ways that they make it possible is through industry sponsors. And so I am happy to introduce the next presentation, which is managing maternal hemorrhage during blood crisis and beyond. So we know that right now, especially, blood transfusion is really something under discussion. Excuse me, because blood is not very available. These presenters, we have Mr. Jim Trickett, who's a retired perfusionist. He's also a clinical specialist for HemoSaver blood collection and transfer. Along with him, we have Mr. Gary Koenig, who's a comprehensive blood man, who is the president and founder of Comprehensive Blood Management. They will talk to us about a device that gives practical application to many of the things that we've learned about during this conference. And so I'm very appreciative of them. I'm happy to introduce them, and I know that you will enjoy their brief presentation. So gentlemen, we await your information for us.
Thank you, Rita. Definitely appreciate that. And I'm going to share my screen here. Okay. Can everyone see my screen there, hopefully? Okay, hello everyone, and thank you for joining us to discuss managing maternal hemorrhage during the blood crisis and beyond. As Rita said, my name is Jim Trickett. I'm a past perfusionist from Cleveland, Ohio, and I am the clinical specialist at EcoMed Solutions for the HemoSaver blood collection and transfer device. Today, we will discuss the blood crisis, the current landscape of cell salvage and obstetrics, and finish with some insights on using HemoSaver in C-sections. First, let's discuss the blood crisis, and I will be brief. We're all very much aware of that. We all know that managing allogeneic blood transfusions is challenging, costly, and complex. Even before COVID, we were seeing increased demand and shrinking donor pools, and COVID definitely amplified that problem. 2 years ago, as the pandemic was just starting, those of us in the PBM space knew that if we didn't open ourselves to better solutions, we were bound for disaster. We didn't want to be vindicated, but in January of 2022, the American Red Cross declared the first ever blood crisis and the worst blood shortage in over a decade that has persisted for months. The HemoSaver is a new option for blood management programs that can help alleviate the stress on the blood supply. It is a sterile, economical blood capture and transfer device that helps clinicians quickly recognize, quantify, and respond to unanticipated blood loss during any surgical procedure at a moment's notice. The severe blood shortage has made patient blood management and cell salvage more important than ever. We should be collecting shed blood every opportunity we have to accurately evaluate that blood loss for return to the patient. The HemoSaver can be used in any procedure that has the potential to bleed, and we know which procedures benefit from expanded collection and salvage. You cannot salvage what you don't collect, and right now we can't afford to throw away shed blood. One area we've been focusing on recently is cell salvage and obstetrics. Obstetric hemorrhage is a leading cause of preventable maternal morbidity and mortality worldwide, and rates of maternal mortality are increasing worldwide, even here in the United States. Obstetric organizations worldwide are now recommending the use of autotransfusion during severe peripartum bleeding. On January 1st, 2021, the Joint Commission issued 2 new standards to help prevent maternal harm by improving recognition and response to hemorrhage. The requirements include having the tools and training to quickly recognize hemorrhage and being prepared to treat hemorrhage. The HemoSaver is the perfect tool to help clinicians manage maternal hemorrhage. Collecting shed blood helps avoid inaccurate blood loss estimates and reduces mortality and morbidity associated with allogeneic blood transfusions. There is some exciting new data from UPMC that Dr. Jonathan Waters touched on this week, demonstrating that even vaginally collected shed blood results in a safe salvage blood product. The UPMC protocol for cell salvage during vaginal obstetric hemorrhage using HemoSaver will be published in the June edition of the Transfusion Journal. Be sure to look for that pioneering article. Today, we'll be focusing on using HemoSaver in C-sections. At this time, I'd like to introduce Gary Koenig. Gary is as Rita said, Gary's a perfusionist and founder and president of Comprehensive Blood Management out of Spartanburg, South Carolina, and has been using HemoSaver the past couple of years. So I'll give it to you, Gary.
Thank you, Jim. I really appreciate this opportunity to be here with you today. we have some very interesting data to share with you. I hope you find it as appealing as we have and can see the benefit for patient blood management. I have no relevant financial disclosures to report either. Evaluation of HemoSaver to recognize, quantify, and respond to hemorrhage during C-sections. Our objective at one of the hospitals we cover at Spartanburg Regional in our company evaluated the HemoSaver's ability to meet new Joint Commission standards to recognize, quantify, and respond to maternal hemorrhage during C-sections and impact on patient outcomes. Our background was patient blood management is underutilized in obstetrics as far as autotransfusion is concerned. It's believed that in the past that you could not salvage blood in OB cases because of potential contamination of amniotic fluid. That really, I'd like to make a point there. In my 28 years of being a perfusionist, I think I can count on my hand the number of times a Jehovah's Witness has refused cell saver or salvage blood when they're explaining the benefits and the alternatives and the risk. The biggest resistance we've had in giving back blood in OB in our C-sections here at the hospital was from our fellow clinicians, from the OB doctors to the nurses, nurse anesthetists, anesthesiologists, even the scrub techs. The first thing they say is, I did not think you could use a cell saver with amniotic fluid. And as has been mentioned on several presentations this week, that is the old school of thought, and it's not true. Blood salvage can be safely done in obstetrics by discarding the majority of amniotic fluid to a waste canister and by using a leukocyte reduction filter when processing shed blood with the cell saver. We implemented the following protocol in all C-sections, focusing heavily on obtaining accurate QBL, quantitative blood loss for patients. Our setup was we used 2 HemoSavers to collect amniotic fluid and shed blood separately. The picture on the right, as you can see, we have 2 HemoSaver canisters set up. One, all or most all of our amniotic fluid is suctioned into that canister. The other canister is used for our shed blood, and that's the blood that potentially, once we quantify the amount of blood loss, we would be able to give that blood back to the patient. So we recognize and collect. Collection of amniotic fluid and shed blood is performed by the existing staff. We use separate vacuum sources to control suction for each of the HemoSavers, and we add anticoagulant to the shed blood canister. We also quantify that blood loss. The lamps, as the picture on the bottom, are rinsed, and that blood is suctioned into the HemoSaver. We draw samples from each canister using the sampling port. The picture on the right, as you can see, is a very simple process to do our QBL. There are other types of QBL that can be done, such as weighing, laps, pre and post. The only question I have is when they have laps that are saturated in blood, what if there's some saline mixed in with that? How do you differentiate between the weight of that lap, how much is blood, how much may be saline? And the same can be said for the canisters. If blood, amniotic fluid, and saline is mixed in a canister, how do you divide up the weight of each one of those? Using the HemoSaver, there's a port, as you can see. We attach a stopcock. We pull 10 mLs of the blood from the bottom, because there's a dipstick that goes all the way to the bottom of this canister. From that, we take a sample and use a point of care analyzer to measure the hemoglobin. From that, we can get the accurate amount of blood loss. But the most important part of using the HemoSaver is that we're able to actually measure the number of red blood cells in the canister, not only the amount of blood loss, but the amount of red blood cells. So we calculate the quantified blood loss using the HemoSaver in both the amniotic canister and the shed blood canister. The goal is to get and suction all of the blood on the surgical field and the blood from the laps to both of these canisters. Then we can quantify, and then we make a decision to respond. Our response in this protocol that we set up was if we had equal to or greater than 125 mLs of red blood cells in the canister, and that's not blood loss, that's red blood cells that we would be able to give back to the patient. If we did, we used the cell saver and performed auto transfusion and returned autologous blood back. If we did not process, and we just discarded the shed blood canister. So some of our results is we returned autologous blood to 59% of all C-section patients. The first 4 months that we looked at this, the number of patients that we were able to collect blood from was 135. The actual number of patients that had enough blood to process and give back to the patient was 79. Why did we not give blood back on 90 patients instead of 79? Again, this goes back to the old thought of amniotic fluid. We always ask the surgeon, we tell them the blood loss, we say, hey, we can give your patient back 200 mLs of blood. They came in anemic. Some of the surgeons say, no, I just want to wait, or no, I don't think so. So the point is that 67% or 90 out of 135 of C-section patients, keep in mind too, there were a few that were Jehovah's Witness patients. There were a few that had or were considered high-risk patients, such as placenta accreta or eclampsia. The majority of all these C-section patients we're talking about in this data were regular C-section patients coming in for surgeries that were not considered high risk. 79 of the 90 patients received autologous blood back. We averaged giving each patient back 203 mLs of red blood cells. Also, I need to make a point. We gave back 203 mLs. So if the hematocrit and the hemoglobin, the hematocrit in the HemoSaver canister was 30%, that would have been a 600 ml blood loss to be able to return 203 mLs of blood. So the red blood cells, the amount of red blood cells returned equated to 64 units of bank blood. Normally, a pack unit of red blood cells from the blood bank has around 250 mLs. So that equated again to just over 64 units of bank blood. So we're assuming $1,400 per unit. Blood is very expensive. The raw cost of blood to hospitals is $200 to $300. This figure was taken from a handout that was put out by Sabum about 3 or 4 years ago, showing the median cost of 1 unit of packed red blood cells. Some studies show anywhere from $600 to $2,500 per unit. This figure of $1,400 per unit is probably now considered to be a conservative figure. The reason is over the past 2 years, we've had COVID, so there are additional tests the American Red Cross and other blood centers have to perform. The cost of labor for the people working for the blood collection centers has gone up. Hospitals pay for these increased tests and these increased costs. Even in our own hospitals, over the last 6 months, all of our blood product costs have increased substantially. So if we save 64 units of bank blood, it's equivalent to, and each unit is $1,400 conservatively, we saved the hospital within 4 months, $90,000 on blood products via increasing autologous blood during this period of time. The goal would be obviously to give back all the blood you can, the autologous blood, to all patients. That would be the goal. So if we have 100 patients that could have received their blood back for C-sections, I believe 100 should have received their own blood back. So we look back on our post-op hemoglobin and hematocrits, As you can see, patients receiving autologous blood had better outcomes than patients that did not receive blood, despite losing more blood. A category on the top left, we had patients that did not receive autologous blood back, and then we had patients that received autologous blood back. So we went back and looked at, again, post-op hemoglobin and hematocrits before they were discharged. We evaluated 91 C-section patients at the hospital that had post-op hemoglobin and hematocrits recorded in their charts. Patients receiving autologous blood back, those patients had lower pre-op hemoglobins and lost 43% more blood during surgery on average. They left the hospital with hemoglobins closer to their preoperative baseline, and they had hemoglobins higher than patients not receiving blood postoperatively. As you can see on the graph up top, the average QBL, quantitative blood losses for patients that did not receive any blood back that could have, was 610. The average amount, the QBL of autologous blood, was 871. So our patients that received blood back and had lower starting pre-op hemoglobins had more blood loss. As you can see on the graph on the bottom right, on our y-axis, we have hemoglobins ranging from 8.5 to 11.5. On the x-axis, we have our average pre-op hemoglobin and our average post-op hemoglobin. Our black line shows the patients that came in with an 11.1 pre-op hemoglobin, did not receive autologous blood back, and left the hospital with an 8.9 hemoglobin, versus the patients where we were able to process and give blood back via the HemoSaver and Cell Saver. That we came in anemic, less than 11 at 10.6 hemoglobin, but we left the hospital. Those patients were able to leave with a much higher hemoglobin at 9.7, even when they lost 43% more blood on average during surgery. What are the patient implications of having anemia postpartum? You have a decreased immune function, you have impaired physical work capacity, you have defects in cognitive function and mood. Postpartum depression is more prevalent in more anemic patients postoperatively. And some studies have also shown the there's a negative relationship of anemia to the amount of lactation and milk produced in moms who have low hemoglobins. We determined the HemoSaver helped meet the new Joint Commission standards to recognize, quantify, and respond. I've said those words 3 times during the presentation. We want to recognize. It cost about $25 only to set up a HemoSaver with a suction line during surgery. That way, we're able to collect blood. We're able to quantify it by doing a QBL through the sample port on the HemoSaver. And I want to say that the HemoSaver is the only reservoir on the market today that you can take a sample like that and get an accurate blood loss. And also you can even measure the number of red blood cells you can give back to your patient if you choose to use the auto transfusion or Cell Saver. Now, I understand that there are some people listening to us today that do not have access to a Cell Saver in your hospitals. I want to commend you for what you're doing with the resources that you have at your disposal to improve patient outcomes and patient blood management. For the ones, and that's the majority of you that do have a Cell Saver at your hospital, you strongly, I believe, need to consider doing these things, recognizing the blood loss, quantifying how much you've lost, and then you make the decision to respond or give blood back. Auto transfusion is an effective way to address the blood shortage in any surgical setting. The data I've shown today, we presented today, over the last 2 years that we've collected has shown in obstetrics and even in regular C-sections, you too can have these results. We can keep the patient's hemoglobin increased, and that is the whole purpose of patient blood management. All the things that we do, whether we're going to pre-anemia clinics and pre-optimization, giving oral intravenous iron, using drugs in surgery such as tranexamic acid, hemostatic agents, using pediatric test tubes, taking less samples during hospitalizations. All of these things are to optimize and to keep our hemoglobin of our patients higher. You never know what's going to happen. I can't control how much fluids anesthesia may give and contribute to hemodilution. If a patient leaves the surgery and has some bleeding, they may have to come back and be opened up and reoperated on. The benefit of the HemoSaver is to accurate blood loss calculations, which can lead us to better clinical decisions in surgery and also better outcomes. Reserving blood processing equipment and resources after sufficient blood has been collected improves the cost effectiveness of cell salvage. It is time to embrace new options for patient blood management. And I would like to challenge each of you listening today to understand that if we do not collect this blood, we don't have the opportunity to give it back. Again, not only in obstetrics, this is important in most all surgeries. We have an opportunity that I think has not been explored. My expertise is working in the operating room. I live in the OR. This is all I've done for 28 years. And I see the benefit of this, but I also see there's not been much attention paid to what we're able to do when you combine the HemoSaver and then we can do auto transfusion. This should be a standard of care, I believe. Our goal is to keep the red cell mass of these patients high as possible. This is an area I think that we need to pay more attention to.
Thank you, Gary, for presenting and some very incredible insights. Very much appreciated. I would like to thank everyone for spending part of your day with us. And if you would like more information or have any questions, please contact us through our website, hemosaver.info, and feel free to scan the QR code there. It'll take you to the website as well. Any questions or?
Thank you so much for that presentation. That was very helpful, very interesting. Natalie, let me ask you, do we have time to take a couple of questions? I see that a couple of participants have their hands up. Natalie?
I think that might be a better question for Dr. Osoro. I think it's supposed to finish at past, but if he's happy to have questions, I'm happy to go with the flow.
Okay, and we are not hearing from him. So, all right, sorry. Hold on to your questions and contact them through their website. Really interesting presentation. This is a very practical application. So thank you so much for all staying with us and listening today.
Thank you.
Thank you, everybody, for staying on. It was a great program. And so we'll just look at the program for tomorrow. Don't forget to come back. And we can actually look forward to more interesting discussions tomorrow. Thank you, everybody.